So today's video is about the respiratory system, and we're going to be covering basically the parts of the respiratory system as well as how air is going to move in and out and be exchanged with the bloodstream. So we're going to start in what is considered the upper respiratory tract. The upper respiratory tract is going to consist of the nose, the palate, the sinuses, as well as the pharynx, the tonsils, and the larynx, which we'll talk about on our next slide. Okay, so the job of our nose is going to be basically it's going to help purify the air. So as many of us are aware, right, our nose is going to be lined with mucus as well as hairs. And so the mucus, it's going to be sticky, and the hairs as well are going to be coated in the mucus. Those are going to help trap the particles that we breathe in through the nose. So the nose is going to help purify the air. It also has olfactory receptors built into it. They're in the roof of the nasal cavity. The olfactory receptors, those are our smell receptors. So those are responding, sending messages to our brain about the chemicals that are coming in the air and coming in contact with those. So all of that is going to be, this is all our nasal cavity here. And so those olfactory receptors will be along the top here. Okay, and then we also have these folds. These folds are, you see here, here, and here. Those folds are what are called the nasal congi. I know there's no G in there, but that's how it's pronounced. Okay, and what those are going to help do is they are going to actually increase surface area. And by increasing surface area and causing turbulence, basically they kind of move the air around. They make it so that more of the air is going to come in contact with the mucus and the hairs to improve filtering. So basically what they will do is as you breathe in, instead of the air just moving like straight through a tunnel, they'll make the air swirl around. And so more of it's going to be coming in contact with the actual nasal cavity for filtering. Okay, next we have the palate. So this is the palate here. That is going to, sorry, I thought I had changed colors. So this is the palate here. It's going to separate the nasal and the oral cavities. Okay, so separates the nasal and oral cavities. So basically the nose and the mouth. We have the hard palate and the soft palate. The hard palate is this anterior portion here. So that's our hard palate. Again, it is anterior, so it is more towards the front, and it is going to be made of bone, where the back portion here, that is the soft palate, and the soft palate is going to be more muscular. And again, it will be located in the posterior aspect of the oral cavity, between the oral and the nasal cavity. So hanging down from that soft palate is what we call the uvula. Let me clear this up. There we go. So the uvula is the thing that hangs down in the back of your throat. So here's the uvula here. And so that's what the doctor's looking at when they tell you to open your mouth and say, "Oh," they're looking to see how that moves. That's when when you look at those images of the open mouth, right? And that's the uvula that's hanging down in the back when somebody says, "Ah." Okay, and so the uvula is going to help prevent food from going up into the nasal cavity. So when you swallow, the uvula is going to lift up. It'll kind of swing up and close off that nasal cavity there. Okay, and the last portion here that we're going to talk about on this picture is the sinuses. We've talked a little bit about sinuses before when we talked about bone. These are going to be air-filled cavities. We can see on the side view here, we can see one here and one in the front here. That's going to be the frontal sinus there, This will be one of the sphenoid sinuses here in the back. So we have 4 basic locations for our sinuses: frontal, in that frontal bone, kind of right above the eyebrows; ethmoidal, so in the nose, in that ethmoid bone; sphenoid, deeper in the skull, like you can see on the picture here; and maxillary, so right there on the front, kind of, remember the maxillary bone is the your upper jaw. So right there, kind of on the front, a little bit inferior and lateral to your nose. So those are the 4 sinuses. Their job is going to be to help basically lighten your head so it's not solid bone. They're going to moisten and warm up the air. They are also lined with mucus, so that helps them moisten and warm up the air. And they help amplify your voice. Think about when you have a cold or a sinus infection, how your voice can kind of change a little bit. That's because these sinuses are filling, that mucus is being overproduced, and they're filling with mucus, which makes our voice sound a little bit different. Okay, the next portion of the upper respiratory tract is the pharynx, which is divided into the nasopharynx, oropharynx, and laryngopharynx. So all of these have pharynx on the end of them. Okay, so basically our pharynx is our throat. So all of this is pharynx here. Okay, and we have nasopharynx back here behind the nose. We have oropharynx back here behind the mouth. And then we have laryngopharynx down at the bottom by the larynx, which is our voice box. Okay, the tonsils are lymphatic tissue. So lymphatic tissue is a type of immune tissue. So they are lymphatic tissue, and we have 3 basic clusters of them: the pharyngeal, the palatine, and the lingual. Okay, so the pharyngeal would be up here in the high back of the throat, base of the nasal cavity. These would be the palatine at the end of the palate. Oops. And these would be the lingual at the base of the tongue. Lingua is tongue. Okay, these are a first line of defense. Their job is going to be to help trap pathogens. They're not an only line of defense, though, which is why you can get them removed, and it's not, necessarily a big deal. And then the last part of the upper respiratory tract is the larynx. The larynx is our voice box. So you can see the larynx is this portion down here. That's why the back part of the throat there is called the laryngopharynx. And so the larynx is our voice box. So it's made of cartilage plates. And those cartilage plates are going to help give the support and the stability there. That's what you're seeing on the front here. They look kind of blue. Those are the cartilage plates. That one at the top there is the thyroid cartilage plate. It is the biggest. That is what makes the Adam's apple in males that will thicken up as they go through puberty. So that's this front bigger one right here. That's the thyroid cartilage there. Okay, and in the larynx, in that voice box, we're going to have what's called the epiglottis and the glottis. And so the glottis is going to be the space between our vocal cords. When we look down onto the vocal cords, they're like 2 leaflets, and there will be a space in between them. And so the glottis is going to be the actual space between the vocal cords. So if you play an instrument or anything, they're like a reed instrument, and the air can move down through them, and they will vibrate as the air moves through them, which gives us our different sounds. And so the space between the vocal cords that allows them to vibrate is the glottis. And what we don't want is food going down there. So the epiglottis is going to, kind of like the uvula prevents food from going into the nose, it's going to prevent food from going down the trachea. The trachea is the windpipe. So your throat at the top is going to have, so this portion of the pharynx here is going to have food and air pass through it. And then in the back, we have the esophagus, which is just going to have food. And then in the front here, we have the trachea, which will have the air move through it. And this flap right here is the epiglottis. And you'll notice it's attached. See here, it's attached at the base of the tongue. So when we swallow, our tongue, if you think about it, if you do a big swallow right now, your tongue will go up to the roof of your mouth because helping force things back down your throat, which will then pull this epiglottis. It'll make it fall down like that. And so now food can't go down your trachea going through the glottis there. So the lower respiratory tract is going to consist of the passageways for air as well as the lungs and the alveolar sacs where you're actually going to have actual gas exchange. So the trachea is going to be our what we call our windpipe. It's labeled here as G. That would be our trachea. And so the trachea is going to be lined with mucus and ciliated epithelium. Remember, that's going to be that epithelial tissue that had the hairs on it. And those cilia are going to sweep particles back up so you can cough them out, get rid of them. Okay, it is in front of the esophagus. Oh, I can't spell. So it is the back side of it is not, it's lined with cartilage plates. And so it's reinforced with these C-shaped rings so that if this is my esophagus in the back here, and this is my trachea tube in front of it, so there's my trachea. The tracheal tubes are these C-shaped rings, so they'll wrap around like this to help support the tube, but the back does not, so that if you have big pieces of food, it can expand into that trachea and it not be a problem. You're able to swallow it and move it down through the esophagus. So it allows the esophagus to change shape as we're eating and we're swallowing the food. So the trachea is just a conducting passage, so no gas exchange is happening here. It is solely for the passageway of air. So are the bronchi. And the bronchi are where we're going to branch off into the right and the left lungs. And we've got multiple levels of bronchi. So we first have our primary bronchi, and we're going to have a right and left one of these. So this would be the left primary bronchi, and branching over here to the right lung would be the right primary bronchi. So these are at the base of the trachea where it's going to split and go out to the lungs. From there, the bronchi will continue to divide by branching out. And so they will continue to branch out into secondary, tertiary bronchi, so getting smaller and smaller and smaller, all the way down to bronchioles, which will be the very small, tiny little tubes. So you can see this happening in the diagram over here on the right. This, so I've got my primary bronchi branching down to secondary, tertiary, and bronchioles, which are going to end in those alveoli. Again, these are complete conducting passages. No gas exchange is happening here. Okay, so let's look at the alveoli where actual gas exchange is going to happen. So the alveoli is going to be our main site of gas exchange. They are going to be made out of simple squamous epithelium. Remember, simple was one layer. Squamous were those really thin, kind of flattened cells. And so this is what's going to allow the gas exchange to happen. The alveoli are lined with a chemical called surfactant. Surfactant is going to help decrease surface tension, and it keeps our lungs from completely collapsing every time we breathe in and out. This is actually one of the last things to be produced during fetal development, which is why babies can't breathe on their own at first. Because if you think of it like a balloon, right, like your lungs are like a balloon, they expand, right? And then they go back down as we breathe out. But what they don't do is completely close back up when you breathe out. Otherwise, you'd have to think of it as like basically reinflating your lungs from scratch every single time. And that would be very difficult. And so the surfactant helps prevent that from happening. Then we also have these, what are called the pores of Kohn. And so those allow for movement of gases and macrophages between the alveoli. So you can see in this image here, the alveoli are sometimes described as a cluster of grapes. So each one of these little circles here is an alveoli. That's why alveolus is one of them. Alveoli is plural. And so to allow for gases and macrophages for immune purposes to move back and forth between them easily. We have these bigger openings or these pores, you can see one right there, between the different alveolar sacs. So the alveoli are going to be completely surrounded by capillaries. And so the capillaries, remember, are those blood vessels where actual exchange is happening. So by these alveoli being surrounded by capillaries, it allows for easier gas exchange. Okay? What this membrane does is it gives us a large surface area so we can have lots of exchange happening here. There are very thin walls to make exchange very easy. Again, those simple squamous cells. And we've got diffusion working in our favor. Remember, diffusion is when things move from high to low and it doesn't require any energy. And so as you can see in this second image here, we've got oxygen diffusing out into the capillaries and CO2 coming back into the lungs to be removed from the body. So the lungs themselves surround what's called the mediastinum. The mediastinum is where we're going to find the heart. So the heart would be located there in between the lungs. So the lungs surround the mediastinum. The apex is the top here, unlike the heart. Right, so the apex is the top there. It is up by your clavicle. Your lungs go all the way up. Your clavicle is your collarbone. Okay, so your lungs go all the way up by your clavicle there. And then they rest, the base is down on the bottom, resting on the diaphragm. And we'll look at how the diaphragm works in just a minute. We do have a right and a left lung. The right lung is going to be divided into 3 lobes, and the left lung is only divided into 2 lobes. And then the pleural sac is a serous membrane that is going to surround the lungs. Remember, serous membranes were those double layered membranes that had serous fluid in between the 2 layers. And we had the parietal layer and the visceral layer. The parietal, this is pleura because we're talking about lungs. Remember, the parietal layer would be the one that is touching the thoracic cavity, the body wall, and the visceral pleura is the one that is actually touching the lungs themselves. And we see those serous membranes when we need to decrease friction, right? So every time those lungs expand and collapse as we are breathing in and out, that will decrease friction there so it is not painful for us as we breathe in and out. Okay, so let's talk about how we get air actually into our lungs. So technically, respiration is only the breathing part, not the actual gas exchange. Right? And we have different parts of respiration. So we have the actual pulmonary ventilation. Pulmonary ventilation is literally the movement of the air in and out of the lungs. So inflating the lungs, deflating the lungs. And this is going to occur due to Boyle's law. Boyle's law reminds us that we have an inverse relationship between pressure, in particular air pressure here, between pressure and volume. And we'll talk about what that looks like in just a minute, what that kind of means for us in just a second. Pressure and volume. Okay, so when we breathe in, that is our inspiration. So inspiration, we commonly call it inhalation. That is breathing in. Okay, and then when we breathe out, that is going to be our expiration or our exhalation. So let's talk about how those happen. Let's use the diagram over here on the side. So when we breathe in, our intercostal muscles are going to contract. So those are the ribs, the muscles between the ribs, between costa rib. So those intercostal muscles contract, which will pull our ribs up and out. And the diaphragm is going to flatten out. And so the diaphragm is going to flatten out. What happens is I increase volume in my chest cavity. If I increase volume in my chest cavity, then I've decreased pressure. This is our Boyle's law coming into play here. And so if we look at our numbers here, now I have atmospheric pressure is greater than the pressure inside of the body. So now I have air going into the lungs because I increase the volume, which is going to decrease the pressure. Then when it's time to go ahead and breathe out, the diaphragm is going to rise up. And so if the diaphragm rises up, that decreases the volume, which is going to increase the pressure. Again, Boyle's law. So now if we look, my pressure inside is greater than my pressure outside, and I push air out. Okay, so expiration is normally a passive process, just naturally those muscles relaxing back down, diaphragm relaxing back up, okay, unless we are forcibly trying to blow air out, or we have an increased respiration rate. Maybe we've been exercising or something like that. We also have air movements in and out that are what are considered non-respiratory. So they're movements of air that are happening not necessarily for gas exchange to bring oxygen in and to release carbon dioxide. So coughing would be an example of that, right? Clearing out dust, debris. Sneezing, which helps clear that upper respiratory tract, right? The nasal cavity. Okay? Hiccuping, which is a diaphragm is spasming, or yawning. Yawning has unknown causes. There's a theory that it's we're needing to increase our oxygen levels in our lungs, and so we take in a big amount, but that has not been proven. Okay, respiration is controlled or regulated by both neural and chemical influences. Okay, so these will work together with emotions and conscious control. We can consciously slow our breathing down, speed it up, that kind of thing. So the neural control is going to come from those breathing centers in the medulla oblongata in the pons. The medulla is going to help set the pace, right? So the medulla will help set our normal breathing pace. It is going to trigger inhalation. So that's how it will help set the pace by telling you it's time to inhale. And then the pons is going to adjust the rate and the depth. So receiving information from your body and maybe saying that we need to breathe a little bit faster, a little bit deeper, that kind of thing. Okay, the chemical control, a lot of that's going to come from CO2. CO2 has a bigger influence on our respiration than oxygen levels do. We have chemoreceptors that are going to help monitor CO2 and O2 levels, right? Chemochemical receptors. We have central and peripheral ones. Central ones are monitoring our CSF, remember our cerebrospinal fluid. So those central chemoreceptors are monitoring that cerebral spinal fluid, and they're monitoring pH levels that are there, acid-base levels. And if we have a decrease in pH, what that means is we have an increase in CO2 that may need to be taken care of. And then we have peripheral chemoreceptors that we're going to see those in the aorta and in the carotid, those arteries in our neck. So in the aorta and carotid arteries, and these are going to monitor O2 levels, so oxygen levels. And if oxygen is low, then the result is that's going to trigger an inspiration that we need to breathe in. And you can see these kind of laid out for you in the diagrams here. Okay, these last two slides will be mostly all vocabulary. And so it'll be really important that you're practicing with this vocabulary. And we're looking at all these different lung volumes here. And so lung volume is going to vary from person to person. It's going to vary for the normal characteristics that things vary. Age, height, weight, gender, race, all those things can have an impact on our lung volume. And what we're going to look at here are static lung volumes. These are just measurements for one particular volume. So pretty much at some point in time in the inspiration or exhalation process is where we're taking these particular volumes. So our first one is our tidal volume. And our tidal volume is going to be the amount of air that is inhaled during a normal breath. And so on the diagram, hold on. On the diagram, you can see it marked tidal volume here. Okay, so that is a normal breath. It's not tons and tons. Okay, it's about 500 milliliters, but that's what our tidal volume is, the amount of air that is inhaled in a normal breath. Our vital capacity is the amount of air that can be forcibly expired, so forcibly blown out after a maximum inhalation or inspiration. All of these are going to be the amount of air, so I'm not going to keep writing it. So you can see vital capacity is here, right? We took our biggest breath in, so we got to the top here, took our biggest breath in, and the vital capacity is all of this that we can blow out forcibly. So that's going to be our vital capacity. We took as big of a breath as we can, and we blow as much of it out as we can. Our residual volume is going to be the air that never leaves the lungs. Even after that vital capacity forcible exhalation. So we have some air that never leaves the lungs, that always stays there. We can see it down here at the bottom. Okay? And this is important because this allows for a constant and consistent gas exchange, even between our inspiration and expiration. So even between our inhalations and exhalations, we can get a constant gas exchange happening because of this residual volume, because of this volume that is here in the lungs. Okay, our inspiratory reserve volume, that's going to be the air that you could inhale above and beyond a normal inspiration. So you've taken a normal breath, but you kept going. That would be what your inspiratory reserve volume is. I can't spell today. Hold on, let me be able to spell. Immediately after a normal inspiration. So again, if we're looking on our diagram here, right? So here's my tidal volume, right? Which is my normal air that I inhale. And my inspiratory reserve volume is what I could inhale above and beyond that. So my expiratory reserve volume would be the air that I could exhale after a normal exhalation. So we can see it in yellow down here. Again, my tidal volume is my normal movement of air, basically in and out. And then the expiratory reserve volume, I did a normal breath out, and then I kept trying to force it out. That would be what that expiratory reserve volume is. And therefore, then my total lung capacity is going to be my vital capacity plus residual volume. So I can find this a couple of ways. So my total lung capacity would be my vital capacity plus my residual volume, which could also be further broken down into my inspiratory reserve volume plus my tidal volume plus my expiratory reserve volume, right? These things all equal my vital capacity. Let me just erase a little bit right here. Plus that residual volume. Okay, so I can calculate my total lung capacity by taking some of these separate measurements. And then dynamic lung volume is just going to be measurements over a certain period of time. So dynamic lung volumes are going to let me measure air flow because I'm going to be taking measurements over time, where my static lung volume is just one particular measurement, one particular inhalation or exhalation or something along those lines. Okay, and then the last thing we need to look at is external versus internal respiration. So external respiration is going to be when we bring that oxygen into our lungs, and then we have the actual gas exchange that happens between the alveoli and the capillaries. So that's my external respiration. So I'm doing this gas exchange between external gases and my body. And then my internal respiration is going to be now that I've taken those and I'm going to do gas exchange between my capillaries and my tissues. So at the tissue level, I'm going to have this internal respiration, this internal gas exchange. And then my gas transport is just going to be moving those gases to those tissues through the blood. So that kind of wraps up our basic respiratory physiology and some basic anatomy there. And so we'll be practicing with this before we move on to do your lab and assessment.